Welcome to Rhythm and Blues, a story of arrhythmias and cyanosis. I'd like to give a thank you to our sponsors who generously sponsored this talk, to our publishers who allowed us to use a lot of the images from our book, Life-Threatening Cardiac Arrhythmias for the Small Animal Practitioner, to our students, and of course to our pets. In this talk, we'll cover a little brief on normal ECG review, and then we'll go into bradyarrhythmias, tachyarrhythmias, and a little bit at the end on pericardial effusion. When we talk about arrhythmias, it's really important to remember the normal order of electrical activity. In health, there are three intrinsic pacemakers: the SA node, the AV node, and the Purkinje fibers. These tissues can take over pacemaking function of the heart if the previous tissue is not working. So the AV node can take over function of pacemaker activity if the SA node is not working. And the Purkinjes can take over if the AV is not working. So in health, we have three fail-safes just in case the previous one is not working. The reason the SA node works the majority of the time in health is because it is set at a faster rate. So whatever rate is fastest will always win in the heart. So the SA is faster than the AV, which is faster than the Purkinjes. So in order of rate, we have SA, which is fastest, and the SA is just the normal heart rate of that dog or cat. The AV node is less fast, and then the Purkinjes are the slowest. So if the SA node and the AV node are not working and the Purkinjes kick in with an escape rhythm, that will be the slowest rate. And the Purkinjes are usually very slow in dogs, maybe 20 beats per minute, and a fair amount faster in cats. They can be 80 to up to even 120 has been reported in cats. Now that was in health. In disease, any cardiomyocyte can initiate a beat. The key here is that this would be a diseased tissue. So an area of the ventricle that is either ischemic or for some reason is infarcted, that can take over as pacemaker function only if the rate is faster than the SA node. So if we have a ventricular area, an area of the ventricle where the ventricle is beating at 180 beats per minute in a dog, that can take over pacemaking function. Again, the fastest rate will always win in the heart. Now here you can see the SA node at the top of the heart. It gives off an impulse that goes through the atria to the little yellow button, which is the AV node. The impulses coalesce in the AV node and then travel down the His bundle and eventually end up in the Purkinjes. If the SA is not working, the AV takes over. If the AV node is not working, the Purkinjes take over. Now, when we have impulses coming from the SA node or the AV node, they are going in the normal direction down the heart, and we will have an upright and narrow QRS. If we have impulses coming from the Purkinjes, they will travel backward, and we will have a wide and bizarre QRS complex. This is one way we can differentiate ventricular beats from supraventricular beats. So just to reiterate, in health we have three pacemakers: the SA, the AV, and the Purkinjes. In disease, any cardiac cell can become a pacemaker, and the rate will always win. Now this becomes important when we're talking about differentiating an escape rhythm. So that would be where the SA node is not working, the AV node is not working, and we have an escape rhythm coming from the ventricle, and a ventricular tachycardia, which is also an impulse coming from the ventricle. The rhythm will look exactly the same. The rate is what distinguishes whether it is an escape rhythm, which will be a slow rate, from a tachycardia or ventricular tachycardia, which will be a fast rate. Okay, now we're going to move on and talk about bradyarrhythmias specifically. Due to time, we won't have time to discuss sinus arrest, sinus bradycardia, or sinus arrhythmia. However, I do want to mention that sinus bradycardia is never normal in a cat in the hospital. When we see a sinus bradycardia in a cat in the ER, the two biggest and fastest rule-outs we have are hyperkalemia and sepsis. Sinus arrhythmia is also never normal in cats. It can be normal in dogs, but it's never normal in cats. The three bradyarrhythmias we'll cover are sick sinus syndrome. It is also called bradycardia tachycardia syndrome, atrial standstill, and heart block. Sick sinus syndrome used to be considered a disease of middle-aged miniature schnauzers. However, it has subsequently been found in Cocker Spaniels, West Highland White Terriers, and many, many different mixed breeds. So it is a disease of any dog. It also used to be thought to only be the sinus, that the SA node that was affected. And now it's known to be disease of the SA node, the AV node, the junction, the bundle branches, and cardiac tissue at all levels. This is an ECG from a dog with sick sinus syndrome. What you can see, if you look at lead 2, which is in the center, you see some relatively normal looking beats, upright and narrow QRS complexes, and they're followed by a very, very long pause. This is a sinus arrest where nothing is happening. Now, the way that we know that it is more than the SA node that is affected here is that we should have had the AV node kick in by now. This is a very lengthy pause, and at this point, the AV node, had it been normal, would have kicked in with some escape beats. And even potentially the Purkinjes are abnormal because they may have kicked in by now. This is a kind of a sinus arrest that would very likely cause a dog to pass out or have a syncopal episode. Sick sinus syndrome is thought to be about antibodies against nodal tissue. At least this is what's been found in humans. It hasn't been documented in dogs, but this is what the suspicion is. It is an occurrence of sinus bradycardia, sinus arrest or flatline, and supraventricular tachycardia. So often what you'll see is there'll be a period of bradycardia or sinus arrest, and that will be followed by tachycardia. So this is more appropriately called bradycardia tachycardia syndrome. And it's important to keep that in mind because the bradycardia tachycardia syndrome tells you that treating the bradycardia will make tachycardia worse and vice versa. And we'll talk about that more in treatment. So the treatment for sick sinus syndrome is a permanent artificial pacemaker. That is the ideal treatment. Drugs such as atropine or isoproterenol do not work well. They're usually not successful at all. And then drugs that treat the bradycardia will make the tachycardia worse and vice versa. Theophylline is thought to potentially reduce the length of the sinus arrest and may be helpful while waiting for a pacemaker. All right, now we're going to move on and talk about atrial standstill. Atrial standstill occurs when a sinus impulse is formed in the SA node and it's conducted to the AV node, but not causing the atria to contract. So it goes to the AV node, and then the AV node kicks in, goes down the bundle of His, the impulse goes down the bundle of His, and the Purkinje fibers kick in, and we get a normal-looking impulse, but the atria never contracted. So we call that a sinoventricular rhythm. It's faster than the ventricular rate because the activation is coming from the SA node, which is faster than the Purkinjes. With atrial standstill, the QRS is usually normal looking, so it's usually upright and narrow. The one exception would be bundle branch block or when there's disease at other levels of the heart. So the AV node, the bundle of His are affected. In that case, we could get a wide and bizarre QRS. The SA node continues to fire, impulses are transmitted to the AV junction, and we will not see a P wave. So the atrial myocardium is not activated, so we have no P wave. It is seen with atrial disease, so enlarged atria or cardiomyopathy, inherited atrial myopathy, and that's seen in English Springer Spaniels, and also with hyperkalemia. Here's an example of atrial standstill. Lead 2 is in the center. And what you can see are that there are no P waves. We have a relatively upright and narrow QRS complex. And then we have a wide and tall T wave. The tall and wide T wave suggests that this atrial standstill may be due to hyperkalemia. So the treatment for atrial standstill is a permanent pacemaker if the disease is both clinical, so the animal is clinical for the bradycardia, and it's permanent, so some kind of tissue infiltration. In that case, the pacemaker is ideal. If the disease is temporary, so for instance, hyperkalemia, we treat the underlying cause. Now, atropine will not help at all because it won't make the atria contract, and so we don't use atropine. And now we're going to talk about heart block. So heart block can be broken up into first, second, and third degree heart block, or AV block. First degree AV block is where all beats get through the AV node. They're just delayed. Second degree AV block is where some beats make it through and some don't. And then third degree AV block is where no beats get through the AV node. In first degree AV block, we have a delay in the impulse conduction through the AV node. The rate and the rhythm are normal. The P wave and the QRS are normal looking, and the PR interval is prolonged. So greater than 0.13 seconds in the dog and greater than 0.09 seconds in the cat. So here we have a normal sinus rhythm on the left and a first degree AV block on the right. And what you can see when you're looking at the PR interval on the left, it's normal, and on the right, it's delayed. So we have a prolonged PR interval, meaning that conduction is delayed through the AV node. Causes of first degree AV block are drugs, different drugs, digoxin, beta blockers, procainamide. Low dose atropine can prolong it initially, the PR interval, and then eventually it speeds things up. We can sometimes see it in older patients, and we don't generally treat this. So it does not cause any perfusion abnormalities, and it's not treated. Now, second degree AV block is broken up into Mobitz type 1 and Mobitz type 2. Mobitz type 1 is also called WikiVet. Mobitz type 1 is much more similar to first degree AV block in that we don't treat it and we're not very concerned. Mobitz type 2 is much more similar to third degree AV block in that we are very concerned and we usually do treat. So second degree AV block Mobitz type 1 is a progressive elongation of the PR interval until we get a blocked P wave. The P waves are normal, the QRS configuration is normal, and the ventricular rate will be a little slower than the atrial rate due to the blocked P waves. We're looking at the image on the left, and this is a second degree AV block Mobitz type 1. What you can see is we have a normal PR interval to the extreme left, and then the PR interval becomes prolonged, and then even more long, or more prolonged, and then we have no R wave following a P wave, so we have a blocked P wave. With Mobitz type 2, the frequency and severity of the arrhythmia is usually much more intense. P waves are not followed by QRS complexes, and the P wave conformation is usually normal. With Mobitz type 2, the PR intervals are usually constant. The QRS can be normal or abnormal. If the block occurs below the bundle of His, we will often have a wide and bizarre QRS. Here we're looking at the image on the right. This is a second degree AV block, Mobitz type 2. And what we can see is we have a normal PR interval to the left of the figure, and then we have a dropped P wave. We have a P that is not followed by a QRS. Then we have a normal P, QRS, T, and then another dropped P. This is Mobitz type 2, second degree AV block. With Mobitz type 2 second degree AV block, we usually have a fixed relationship between the atria and the ventricles. So there can be one ventricular beat for every 2 P waves, that would be a 1 to 2. There could be one ventricular beat for every 4 P waves, and that would be a 1 to 4. As the numbers progress, the arrhythmia is more severe and the heart rate will be slower because we're having many, many P waves before any QRS kicks in. So we'll have a very slow ventricular rate. So for second-degree AV block, for Mobitz type 1, that can be normal in young dogs, and we can also see it from increased vagal tone. Again, type 1 is not something we usually worry about. We usually don't treat it. Now, second-degree AV block Mobitz type 2 can be seen with disease, so myocarditis, cardiac neoplasia, and the hereditary stenosis of the bundle of His in pugs. We can see second-degree AV block in cats. That is usually cats with diseased hearts, so hypertrophic cardiomyopathy cats. We can sometimes see it with hyperthyroidism in cats, and we can see it with microscopic idiopathic fibrosis in older dogs. Also, we can see many drugs causing second-degree AV block. So when we have the Mobitz type 2, second-degree AV block Mobitz type 2, especially if we have a very slow ventricular rate and a wide bizarre QRS, this can quickly degenerate into third-degree AV block, and we often either watch it very closely or go ahead and treat. When we have Mobitz type 2, second-degree AV block, if we have too many P waves not making it through the AV node, we will get a wide bizarre ventricular escape complex. This can easily, again, degenerate into third-degree AV block, and when the heart rate is that slow, it often affects perfusion. And so the dog will be quiet or lethargic or in some cases syncopal. So this needs to be treated. So how do we treat? We can try atropine and glycopyrrolate and isoproterenol. In general, they're not very successful at all. We sometimes try them just to get the dog through to pacemaker, but the only definitive treatment really is pacemaker. Here we can see an example of second-degree AV block, Mobitz type 2. In the middle lead, we can see lead 2, and we can see that we have multiple P waves without any QRS complex after them. So we can count 1, 2, 3, 4 at the blue arrows, and the fourth one has a QRS after it. So this would be 4 to 1 or 1 QRS to every 4 complexes. And you can see that we have a very slow ventricular rate because of this. All right, now moving on to third-degree AV block. For third degree, there's no correlation between P waves and QRS complexes. There's no conduction occurring between the atria and the ventricles. The P to P interval is normal or relatively constant, and the R to R intervals are relatively constant. And what that means is that the atria are beating, the SA node is kicking out, but nothing's making it through the AV node. So we have an SA node rate, and we have an atrial rate, and we'll see those P waves, and that's pretty consistent. The ventricular escape that is coming from the ventricle, because it's not getting anything through the AV node, will also be constant. So we'll have a constant ventricular rate that's usually quite slow, and that will let us know that we have a third-degree AV block. So with third-degree AV block, we have an atrial rate or a P wave that's normal. We have a ventricular escape rhythm that is slow. The ventricular rate in dogs can be 20 to 40 beats per minute, depending on where it's coming from in the ventricle. If it's coming from the junction, right below the AV junction, it will often be 40 to 60 in the dog and 80 to 100, even up to 120 in the cat. With third-degree AV block, the QRS is usually wide and bizarre. There are exceptions where the impulse is coming from just below the AV node, and we end up with an upright and narrow QRS. The QRS is normal, again, if the pacemaker is near the top of the AV junction. Now, an exception is bundle branch block, and this is a confusing concept for a lot of people. So the bundle branches go out right at the bundle of His, and when we have a bundle branch block, even if the impulse is coming from above the AV node, we will have a normal traveling impulse, let's say an impulse coming from SA node, down the atria, AV node, down the bundle of His, and at one bundle branch, it blocks. When that occurs, we get a wide and bizarre QRS complex. So even though the impulse is coming from above the ventricle, we look like we're coming from the ventricle. So it looks like the impulse is ventricular, and that can be very, very tricky. So here is our heart again, and we see if we have an impulse coming from above the AV node, so if it's coming from the SA node or the AV node, it will travel in the normal direction down the heart, and we'll get an upright and narrow QRS. However, and alternatively, if the impulse is coming from the ventricle, from the Purkinje fibers, we will have a wide and bizarre QRS. The exception is when we have an impulse coming from above the ventricle, so we have an SA node impulse or an AV node impulse, but as it travels down the bundle of His, one of the bundle branches is blocked. That causes our configuration to be wide and bizarre, and we get what looks like an impulse coming from the ventricle, but it's really coming from above the ventricle. So causes of third-degree AV block include congenital defects, digoxin toxicity, it has to be pretty severe, and idiopathic fibrosis of older dogs, and we see it more commonly in Cocker Spaniels. Other causes of third-degree AV block include myocarditis, Lyme's disease, Chagas, and then treatment for third-degree AV block, the only treatment is a pacemaker. Here's an image of third-degree AV block. If you look at lead 2, which is at the very bottom of the strip, you can see multiple P waves without any QRS complex following them. The key here is that, and we do have an upright and narrow QRS, so it looks like the impulse is coming from just below the AV node. Now, the key in differentiating this from a second-degree AV block is that when we do have a P wave, it is not causing the QRS. In other words, the P to R interval is completely different with every single QRS complex. And that shows us that there's no P causing the QRS. Here is a comparison of two ECGs, one from second-degree AV block on the left and one from third-degree AV block on the right. The second-degree AV block shows lead 2 in the center, and the three arrows are pointing to P waves that are at the exact same PR interval to the QRS, the P and the QRS, exact same PR interval of all three P waves. And this shows us that that P wave caused that QRS. If you look on the right, lead 2 is on the bottom, and you can see the arrows showing you that the PR interval is completely random and not in any way consistent. And this tells us that the P waves and the QRS complexes are completely disengaged and there's no connection. And that tells us that that's a third-degree AV block. Here's another third-degree AV block example. Lead 2 again is at the bottom. And you can see that we've got 4 P waves for every QRS complex, roughly 4 P waves for every QRS complex. And so that would be a 1-to-4 ratio, and this would be a slow third-degree AV block. Another example of third-degree AV block, and we have lead 2 in the center here. And what we can see is that we have many, many P waves before we get a QRS. When we do see the QRS complex, it is wide and bizarre. And that tells us that the impulse is coming from below the ventricle or below the AV node and from somewhere in the ventricle. So let's take a break for a minute and talk about a case. We have a 4-year-old male castrated domestic shorthair who was blocked or had urethral obstruction. He had emergency perineal urethrostomy surgery at the veterinarian. And at surgery, he had what appeared to be ventricular tachycardia. So on the ECG machine, he had a wide complex tachycardia, and his heart rate was 260 beats per minute. The question that you want to ponder is what you would do about this. Would you treat this, or would you do something else? This is an example of his ECG. Again, we can see lead 2 is at the bottom. And that's our rhythm strip, and we can see that we have a wide complex tachycardia. It looks wide and bizarre and also fast. So the question to ask is whether this is actually ventricular tachycardia, or whether it's an escape rhythm. We talked about how an escape rhythm coming from the ventricle will be wide and bizarre. However, escape rhythms are slower than ventricular tachycardia. The question is, what is happening at the ECG level? So ECGs will read the highest peak as an R wave. So the tallest amplitude will become an R wave to the ECG. When we have a T wave that is equal to the R wave, it can often double the rate on the ECG. So the ECG is reading the R wave as an R wave and the T wave as a T wave. If we were to listen to the cat, he would have a heart rate of 130, or half of what the ECG is showing. So it's super important whenever you have a cat that you think has VTach to listen to the cat and get a rate by listening to the heart, not just on the ECG machine. Because what's happening in this cat is he is a block cat with hyperkalemia, and he has an escape, so nothing is happening in the top of his heart. His ventricles are beating at an escape beat, and if you suppress those, you'll kill him. So let's talk about hyperkalemia. When we have hyperkalemia, we'll often see large peak T waves. We can see small R waves and a prolonged QRS complex. The PR intervals can sometimes be prolonged, and we can see ST segment depression. We can see a smaller and smaller P wave until there is none, and a wider and wider QRS and wider or longer PR intervals. And eventually we'll see a prolonged QT interval. Now on the right, we see, you'll see letters A through E. And A represents a normal ECG, so we have our P wave, our QRS, and our rounded or humped T wave. That's a normal T wave. And on the right, you'll see approximate serum potassium concentration. So there we have a relatively normal concentration of potassium. In B, you can see that the T wave, as the potassium goes up, the T wave becomes pointy or less humped and taller. And you can see that the T wave is becoming almost as tall as the R wave. And this is what we were talking about, where when the T and the R are the same, the ECG will read it as 2 R waves and double the rate. And you can see as we go down, it becomes more bizarre. The complexes become more bizarre. Now, what's important is that we cannot predict. We can have a cat with a potassium of only 6 with the wide bizarre complexes, and we can have a cat with a potassium of 9 and have relatively normal looking complexes. And that's because calcium, endogenous calcium level, also has a lot to do with whether the potassium is affecting the heart or not. So this is a schematic of an action potential. You can see we have resting potential. Our line at the very bottom is resting membrane potential. And the line above that is the threshold required to be able to achieve an action potential. It's called the threshold potential. What you can see is that when we have high potassium, we raise our resting membrane potential and make it easier to get an action potential. When we give calcium, which is one of the treatments for hyperkalemia, we raise our threshold potential. And what we do when we give potassium as a treatment for hyperkalemia is we normalize the difference between resting and threshold. And that generally gives us about 20 to 30 minutes while we unblock the cat, get fluid started, and then bring the potassium down. So for hyperkalemia, the first treatment that we usually use is calcium gluconate 10% slow IV. The reason we use 10% calcium gluconate is that it allows us to memorize the dose in mils. So the dose is 0.5 to 1.5 mils per kg IV slow. So we usually go right in the middle at 1 mil per kg of calcium gluconate 10% slow IV. And we never exceed 10 mils in any animal. And we'll give that very slow to effect. Of course, we treat the underlying cause, and we do that while we're getting the calcium pulled up. And then other options include insulin and dextrose and sodium bicarb. Now, insulin dextrose has some pros and cons. One of the cons is that giving insulin to a non-diabetic can be dangerous, so we'll often have to keep them on dextrose for 6 hours or so after. And that takes away our ability to monitor for hypoglycemia in case the cat becomes septic. Sodium bicarb has some issues where when we treat with sodium bicarb, we will often cause a tetany or an ionized hypocalcemia. We'll see clinical signs, so twitching or stiffness of the muscles. If we do use sodium bicarb, we always use it with calcium. Now we're going to move on and talk about tachyarrhythmias. The tachyarrhythmias we're going to talk about are supraventricular tachycardia, particularly atrial fib, which is a subset of supraventricular tachycardia, ventricular tachycardia, and then how to differentiate supraventricular from ventricular tachycardia. And then we'll talk a little bit about ventricular fibrillation at the end. So supraventricular tachycardia is rapid rhythms that originate either in the atria, around the AV junction above the bundle of His, or rhythms that involve the atria or the AV junction as a crucial component of a circuit. We identify supraventricular tachycardia by P waves that look different than normal, a QRS complex that usually looks normal, upright and narrow. The exception, again, is bundle branch block, and a PR interval that is usually constant. It can be caused from an abnormal automatic focus in the atrium or a reentry circuit. The heart rate is rapid with supraventricular tachycardia, and the rhythm may be continuous or intermittent. If it's intermittent, it's called paroxysmal supraventricular tachycardia. The causes include dogs with severe heart disease, and it can be congenital in Labrador retrievers, so we'll see it in young labs. And then we can see it in cats with hypertrophic cardiomyopathy or hyperthyroidism. Now, the goal of treatment for most supraventricular tachycardias is not to stop the arrhythmia, but to slow conduction through the AV node. What matters is slowing the ventricular response rate due to the rapid atrial rhythm. So the atria can beat very, very, very fast, but what matters is perfusion, and perfusion is affected by the ventricular rate. So slowing that down is usually enough to improve perfusion. We can try a vagal maneuver, so pressure on the eyeballs or the carotid sinus can sometimes terminate the rhythm, but generally treatment is with calcium channel blockers, so our first choice is diltiazem. Now, diltiazem will slow conduction through the AV node, so it can often decrease the ventricular response rate enough to improve perfusion. I put magnesium in there because it's important to remember that magnesium is a natural calcium channel blocker. And if you do not have diltiazem around, magnesium can often be used and can be very successful. This is an ECG from supraventricular tachycardia in a boxer before treatment. Lead 2 is in the center. And what you can see is we have an upright and narrow QRS, a very rapid rhythm, no visible P waves. Of course, it would be hard to see them anyway because the rhythm is so rapid. And if you were to look at the R to R interval, you would see that it was irregularly irregular. Now, if you look at lead 2 in the center, you can see we have our rapid rate occurring, and then we gave diltiazem. And just as we gave diltiazem, our rate slowed enough that we got an escape beat. And you can see we have a wide basal complex, that's an escape beat coming from the ventricle. And then we have a supraventricular tachycardia at a much slower rate after the escape beat. So diltiazem is slowing conduction through the AV node and slowing the rate enough that we can improve perfusion. So diltiazem is going to slow the AV nodal conduction so that the atrial rate, which can be 300, 400, 500 beats per minute, does not equal the ventricular rate. and we have time for our ventricle to fill and perfuse the body. The goal, again, is slowing the ventricular rate, not controlling the atrial rate. So atrial fibrillation is a subset of supraventricular tachycardia. It is numerous chaotic impulses that are bombarding the AV node, and it accounts for up to 14% of all canine arrhythmias. It's thought to be a 50% incidence in dilated cardiomyopathy dogs. The Irish Wolfhound is an interesting exception. They will often have a normal heart, and they have something called lone AFib. And it's where they have an atrial fibrillation, but with a slower ventricular rate, and so it's often not treated. Atrial fib is usually complete electrical disorganization, and the atrial depolarizations can be 400 to even up to 1,200 beats per minute. And you can imagine that we can't let those beats go through the AV node to the ventricle, or we wouldn't have any time for ventricular filling. So with atrial fibrillation, we have a rapid, irregularly irregular rhythm. No visible P waves. We sometimes see oscillations or F waves, but no visible P waves. The QRS configuration is usually normal. The exception, again, is bundle branch block. So an atrial fibrillation with bundle branch block is going to have a wide QRS complex, and it can mimic ventricular tachycardia. A vagal maneuver may slow AV node conduction and let us know that it was a supraventricular tachycardia. With atrial fibrillation, the QRS complexes may vary in amplitude, but the key with atrial fib is this is the only arrhythmia the owner diagnoses. So in all of the other heart diseases, dilated cardiomyopathy or heartworm disease, or if we have mitral regurg, or if we have congestive heart failure, the owner usually complains about the dog's behavior. He's tired, he's having trouble breathing, he can't exercise. In atrial fib, the owner usually calls and says the dog's heart is acting funny or the rhythm is off. And that's because they can actually put their hand against the chest and feel that the heart rate and the heart rhythm is abnormal. And this is a clue for you that that's probably atrial fib. The bottom, this is an ECG of a dog with atrial fib, and the very bottom strip is a lead strip, and it's a lead 2. Rhythm strip, it's lead 2, and you can see that we have upright narrow QRS complexes, a very rapid rate, and if you had calipers, you could see that this is irregularly irregular rhythm. Here's another ECG in a dog with atrial fib. And this dog, if you can look at lead 2 is in the center, you can see that the rhythm is somewhat slower. We cannot see any obvious P waves. We do have upright narrow QRS complexes. And in some cases, perhaps you see F waves, the oscillation waves. It's not 100% clear, but we definitely don't see clear P waves. All right, now we're going to go and talk about ventricular tachycardia. Ventricular tachycardia is defined as 3 or more ventricular premature complexes in a row. It is from a stimulation of an ectopic focus in the ventricle. It can be intermittent, which is also called paroxysmal, or sustained, and the rate must be over 150 beats per minute in dogs, and the QRS must be wide and bizarre. We sometimes see ventricular effusion complexes. We will, these are a summation of a ventricular impulse and a supraventricular impulse. I'll show you an image of that in just a minute. And the QRS impulse can be of intermediate morphology and preceded by a P wave. You can see here we have a wide and bizarre complex, and then we have, we're looking at the little triangle arrow. So before the triangle arrow, we have an upright, relatively narrow QRS, and then before that is a wide and bizarre. What appears to happen with a fusion complex is that you get the ventricular impulse coming up and the supraventricular impulse coming down, and you get a complex that is of intermediate morphology. So it's sort of half ventricular and half supraventricular. And in some cases, they almost cancel each other out. And so you can see where we have this arrow that we've got this summation of ventricular and supraventricular. And that's kind of a hallmark of ventricular tachycardia. Another hallmark of ventricular tachycardia is a capture beat. These can be seen commonly. And it's a supraventricular impulse that goes through the normal conduction pathway to the ventricle during an episode of ventricular tachycardia. It occurs earlier than expected, and it creates a narrow QRS. So here we have lead 2 in the center again. And if you start from the left, we have a normal, relatively normal sinus rhythm, 1 complex. Then we go into 4 beats of ventricular tachycardia, and then we get our capture beat. The capture beat is highlighted by the blue arrow. The capture beat brings us back into a normal sinus rhythm until we degenerate into VTach again. With ventricular tachycardia, there's no relationship between the P waves and the QRS complexes. We usually can't find P waves due to the rapid ventricular rate. The P waves, however, will have regular intervals, but again, no association. So our P to P rate will be equal or will be consistent, but there's no connection with the QRS complexes. Again, to remember, when we're looking at a ventricular rhythm, so a wide and bizarre complex, it's important to remember it could be an escape. So in an escape rhythm, we're going to have a wide and bizarre complex, and in a VTach, we're going to have a wide and bizarre complex. The key is that the escape is going to have a slower rate. The rate can be as slow as 20 to 40 beats per minute in a dog, 60 to 120 in a cat. Now with VTach, we have the wide and bizarre rhythm, but we have a very fast rate. Remember though that the ECG can double the rate if we have a tall T wave. So if the T wave is the same as the R wave, we can get double the rate, and you've got to listen to that animal to determine if it's an escape rate rhythm or not. We always want to rule out non-cardiac causes of ventricular tachycardia. So the most common causes are, especially in the dog, are hypoxemia, electrolyte or acid-base abnormalities, and pain. Pain is a huge cause of ventricular tachycardia. Other causes of ventricular tachycardia include drugs such as procainamide, sotalol, domperidone, cisapride, chlorpromazine, erythromycin, and many, many other drugs. Treatment for ventricular tachycardia includes, first, always treating the underlying cause. Oxygen therapy, adequate perfusion, and adequate analgesia will often convert some ventricular tachycardias. So we have seen it converted when a dog with a fracture came in, and the dog with an excruciatingly painful fracture came in on a very, 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 very mild analgesic like butorphanol. And when we put that dog on an appropriate CRI of analgesia, like a fentanyl, lidocaine, ketamine drip, the tachycardia went away, and we converted to a normal sinus rhythm. So always, always, always treat the underlying cause. Now, having said that, if the rhythm is affecting perfusion and the dog needs to be treated immediately, or the ventricular tachycardia can sometimes degenerate into a ventricular fibrillation. If it looks like that's happening, we will treat. So our first choice for dogs is lidocaine. Our first choice for cats is procainamide. In dogs, if lidocaine is not working, we'll often add procainamide. Other options that are not as successful in our hands are beta blockers. Sotalol is one that we do treat. We usually prescribe it orally to go home with for boxers with cardiomyopathy and dogs with Chagas. And then don't forget about magnesium. Magnesium can be a phenomenal treatment, especially if you don't have access to lidocaine and procainamide. This is an example of ventricular tachycardia in a boxer. And if you look in the center, we have lead 2. We have a relatively upright and narrow QRS complex. We have 4 complexes that then rapidly degenerate into a ventricular tachycardia. This could almost be a ventricular flutter, which is just before you get ventricular fibrillation. So this needs to be treated. Another example, Lead 2 is in the center, and here we have a ventricular tachycardia or a flutter. This is a really, really, really rapid rate, and there's a very good chance that this will degenerate into fibrillation. Here's an example of ventricular tachycardia in a dog with GDV, or gastric dilatation volvulus. And this dog was treated with lidocaine, but also when the volvulus was resolved, the arrhythmia resolved. Let's move on and talk about some of the nuances in differentiating supraventricular tachycardia from ventricular tachycardia. So the rhythm is supraventricular if the QRS complexes look normal, so they're upright and narrow, and that tells us that the impulse is coming from the normal direction or above the bundle of His. Here's an example of a supraventricular tachycardia. We have an irregular rhythm, so it's an atrial fib, no visible P waves, and upright and normal looking QRS complexes. Now we usually think that we have a ventricular tachycardia if the QRS complexes are abnormal, so they're wide and bizarre, as if the impulse is not coming from above the bundle of His, as if the impulse is coming from the ventricle itself. However, the exception is bundle branch block. So in bundle branch block, we can have a supraventricular tachycardia where the impulse is coming from somewhere up in the atria, and so it's in the supraventricle above the AV junction. But we have wide and bizarre complexes. And the reason we have wide and bizarre complexes is because as the impulse comes down from the SA node through the atria, or from somewhere in the atria through the AV node, when they go down the bundle, one of the bundle branches is blocked, and we get our impulse coming backward, and we get a wide and bizarre complex. In that case, it can be very, very, very difficult to differentiate a supraventricular tachycardia with bundle branch block from a ventricular tachycardia. So some rules to help us differentiate. If we have a wide complex tachycardia and we want to know if it's SVT or VT, the first thing we want to look for are P waves. If we see P waves with a consistent relationship to the QRS, that is consistent with a supraventricular tachycardia with bundle branch block, or it's also called aberration. If we see QRS fusion complexes, that is consistent with ventricular tachycardia. If we perform a vagal maneuver and it terminates the rhythm, that is more likely to be supraventricular tachycardia. And if we give lidocaine and that terminates the rhythm, it's more likely to be ventricular tachycardia. Now, when in doubt, treat for ventricular tachycardia. So if you're not sure, just go ahead and treat for as if it's a ventricular tachycardia. There's a couple of reasons for this. Number one, human research suggests that at least 80% of all wide complex tachycardias are ventricular in origin. And the other reason is that it's much safer to treat this way. So the drugs that we use to treat supraventricular tachycardia, the ones that slow the ventricular response rate, so diltiazem, digoxin, beta blockers, they won't stop ventricular tachycardia, so they will not address it or treat it. But more importantly, they will worsen hypotension. They often have vasodilatory or negative inotropic effects, and they can make the side effects of ventricular tachycardia much worse. So it is safer to treat for ventricular tachycardia with lidocaine or procainamide. All right, now we're going to go on briefly and talk about ventricular fibrillation. Toussaint de Pointes is a particular type of ventricular fibrillation. It's becoming more prevalent due to it being caused by a prolonged QT interval, and a lot of medications are being found to cause prolonged QT interval, certainly in humans. So it is from a prolonged QT interval, and it is seen as rotations of peaks of the QRS complexes. So the QRS complexes seem to oscillate around a baseline or an axis. And so we get this ever-changing geometry of this reentry circuit. It is congenital in Dalmatians, so we have congenital long QT syndrome in Dalmatian dogs. And we can also see it with hypokalemia, hypocalcemia, toxicity, quinidine, and some other drugs. So the second lead from the bottom, or the very bottom lead, is lead 2 rhythm strip. And what you can see is that we have larger or more coarse impulses followed by finer impulses followed by larger or more coarse impulses. Some people compare this to ribbon candy, they call it, and it's basically we're oscillating around a baseline. So this is an example of torsade de pointe. The treatment for this specific arrhythmia, which is a type of ventricular fibrillation and will be deadly, the treatment is magnesium IV, so intravenous boluses of magnesium. So now talking about ventricular fibrillation in general, VFib is a chaotic, uncoordinated depolarizations of the ventricle. There's no contractions happening because all of the impulses are not coordinated, so they're preventing contraction. There's no pulse, there's no perfusion, and the animal will be dead very shortly if something's not done. For ventricular fibrillation, the oscillations may be larger or coarse or smaller and fine. Coarse fibrillation is thought to be easier to defibrillate, and epinephrine may convert fine fibrillation waves to coarse waves. This is why you'll often see us giving epinephrine even during defibrillation. So this is an example of ventricular fibrillation, and you can see this is just chaotic, uncoordinated. And the treatment is defibrillation. Treatment can be with biphasic or monophasic defibrillators. You can use veterinary defibrillators, or you can use one of the AEDs that are common. All right, we're just going to talk briefly about pericardial effusion. This is an image, a radiographic image of an 11-and-a-half-year-old male-neutered golden retriever. And you can note that number 1, if you look at that bar across, we have a generalized cardiomegaly or a globoid heart with an enlarged cardiac silhouette. And this is one of the hallmarks of pericardial effusion. This dog, if you look at number 2 at the arrow, you can see some pleural effusion as well. This is an image, an echocardiographic image of a 9-year-old female sprayed mixed breed dog. And what you can see at the bottom is pericardial effusion. So you can see that the pericardium is that bright line at the bottom, and then the dark line above it is the pericardial effusion. And then what we can see is we have a yellow arrow, and the arrow is pointing to the right atrial wall, which has been collapsed. It's collapsed because the pressure in the pericardium is pushing on it, and this is indicative of cardiac tamponade. So these animals are ones where they will often have an electrical alternans, so every other R wave will be smaller, and they need to have a pericardiocentesis immediately. Okay, so in summary, bradyarrhythmias are never normal in cats, but they can be normal or compensatory in dogs. Any cat with bradycardia, we eliminate hyperkalemia or sepsis immediately. Those are our 2 rule-outs that we want to figure out as soon as possible. If we have an animal with 3rd-degree AV block, we'll always refer to it for a pacemaker. Always do electrolytes first, however, as we have seen severe hyperkalemia in a dog with a ruptured urinary tract that mimic 3rd-degree AV block. And so always, always, always do electrolytes first. Okay, thank you very much. This was great, and I hope you enjoyed it.